Yeah, one more minute. After that, it will start.
Ma'am, your face is not visible.
Your camera.
Camera, if you can just, yeah, that's it.
So.
Shall we go live, sir?
She has given green signal, Veena. Okay.
Okay, no, that was green signal for Suchanda's camera, not us, because we still okay. Now can we go on live at 7:30 or?
Yeah.
Sir.
It's like Shinkansen Express only, 7:30 now.
Yeah. Good afternoon. This is the first session for this year, and today was a good day to start because today is the Saraswati Puja day, where people start means they go to the Saraswati temple to start writing for children. All parents do it for children, and Dr. Professor Nair considers all students as his children. So today he will introduce you to the subject and case presentation. So today we have changed the format of presentation, and we will follow this for this year and see how people like it. The first part of the session will be a lecture by a faculty on an approach to a problem. So today we have Professor Sridhar from Chennai. He is the secretary of NS Neurosciences Society of India, and he will be presenting on clinical approach to foot drop, and followed by a case discussion, which will be discussed by Professor Nair and Professor Sridhar together and Dr. Parikos. And but before I start the program, I will like Dr. Parikos, the new chairman of new Board of Education of NSI, to give his comments, and followed by Suchanda to carry on with the event.
Thank you.
Parikos,
thank you, Dr. Manas. It's indeed a great privilege, and thank you again officially for continuing to do this event, coordinating and this with Suchanda and Chirag. So we will, without wasting much time, we'll just start with the program. We will, as Dr. Manas said, we'll follow first the lecture by Dr. Sridhar, and then we will do a quiz and a case presentation. So yeah, we should just get starting now.
Yeah, Suchanda, can you please coordinate the? We cannot hear you, Suchanda.
Sridhar is muted.
No, I'm not muted.
Suchanda is muted.
Can I share my screen and start off?
Yeah.
And now we can hear you.
Yeah, so Dr. Sridhar is from MGM Healthcare Chennai, and he is the current Secretary of Neurological Society of India. And so it is the best thing to start with the secretary, with the new secretary, new year on a Basant Panchami. So over to you, sir, for your lecture on approach to program.
So I hope you can see my screen.
Yes.
Okay, so this is a short presentation on clinical approach to foot drop. At the outset, other than thanking both the Board of Education and Manas and his team for this opportunity, I also want to thank Dr. Srivardhan, who is a young colleague of mine in neurology, who's given a lot of effort and help in preparation of this presentation. So this is what we are looking at in foot drop. On one side, the patient is able to lift the dorsiflexion, and on the other side, you see that not able to do it. And that's when you get a patient like this, then you need to know what you have to look for in order to diagnose clinically. So basically, foot drop is a condition characterized by inability to actively dorsiflex the foot at the ankle joint. Clinically, the patient presents with a high steppage gait because they tend to walk with an exaggerated flexion of the hip and the knee, and there may be a slapping noise as the foot strikes the floor. Now, what are the muscles involved? And that is very important to know, because only then you can do a neurological exam. The muscles causing foot and ankle dorsiflexion are the tibialis anterior, extensor digitorum longus, extensor hallucis longus, and the peroneus tertius. The TA and the EDL are the principal dorsiflexors, and the TA, in addition, acts as a foot inverter, though it is an additional foot inverter, the primary inverter being the tibialis posterior. Now, if you look at the sciatic nerve comes down here, and then it actually continues as the tibial nerve after it gives off the common peroneal nerve. The common peroneal nerve winds around the head of the fibula, and then it divides into the deep peroneal and the superficial peroneal nerve. The easy way to understand this is that the superficial peroneal nerve is more involved in the cutaneous distribution, that means sensations, but it also supplies the peroneus longus and brevis. While the deep peroneal nerve supplies the muscles, basically the tibialis anterior, extensor digitorum longus, hallucis longus, peroneus tertius, but it also has a very small cutaneous distribution in the first interosseal web space in the foot. So basically, if you look at the roots, you have the L4, L5, and S1, but basically L5. And these are the ones that in various ways divide and they supply these muscles which are involved in dorsiflexion of the foot and the ankle. So you can have a problem with the sciatic nerve, you can have a problem with the common peroneal nerve, you can have a problem with the deep peroneal nerve when you have a patient with a problem with the foot drop. But what you need to look at is you need to look at the L5 radical, you need to look at the lumbar plexus, sciatic nerve, CPN, and the DPN. And then you would have to differentiate as to which is what in your particular patient. So if you look at the deep peroneal nerve, it primarily involves the foot dorsiflexion. Foot eversion is relatively preserved because only the peroneus tertius involvement is there, and therefore it is preserved. You have a sensory loss of the dorsum, the first web space, preserved ankle, and you may or may not have a positive Tinel sign. So this is the picture to remember, where you can get the sensory loss only at the dorsum, the first web space. And these are the etiological factors which can cause a deep peroneal problem. So if you look at the, common peroneal neuropathy or problems involving the common peroneal nerve, when that happens, it affects both the foot dorsiflexion and eversion. You have a sensory loss over the dorsum of the foot and the lateral part of the calf, preserved ankle, DTR, with or without a positive Tinel sign. And this is what happens. So now the sensory loss extends to the lateral part of the calf and over the entire dorsum of the foot. And you also have eversion, which was not there in the deep peroneal involvement. So the problem, possible etiological factors are all these, and these are all the differential diagnosis which you would have to rule out from your history. Now, when you have a sciatic nerve involvement, you have weakness of both dorsiflexion and eversion, but not only that, you will also have a problem with foot plantar flexion and inversion, because that is supplied by the tibial nerve and that also gets involved. And therefore, you also get a sensory loss of the entire leg and foot, except the medial part of the leg, which is supplied with the saphenous nerve, which is a continuation of the femoral nerve. So remember that the medial aspect of the leg will be spared in a sciatic neuropathy. You have an absence of the ankle DTR, and you may or may not have a positive SLR test positive. So this is what happens when you have the sciatic nerve involvement, and etiologically, this can be caused by all these problems which you need to look at. Now, when you have a lumbosacral plexopathy, you can have a combination of any of these, of weakness and sensory deficit. So it starts from the hip flexion, knee extension, sensory loss of the medial part of the leg, absence knee reflex. If you have, that suggests lesion beyond the sciatic nerve because it goes above. And etiologically, all these can be involved. Now, what about L5 radiculopathy? So you must remember that the L5 innervated muscles involves also the gluteus muscles, the tensor fasciae lata, other than the tibialis anterior posterior and the EDL and the EHL. And therefore, when you have a foot drop associated with weakness of hip abduction, you must think of an L5 radiculopathy. You also have weakness of the ankle dorsiflexion and inversion alone, and your ankle DTR is preserved. Sensory loss is not very well appreciated because there is a lot of significant overlap of the sensory dermatomes. So you may or may not get a significant sensory loss. But most important is the foot drop with weakness of hip abduction, which must alert you to the fact that probably it's an L5 radicular involvement. Now, so if you take into consideration all the clinical features which you may get in a patient with a foot drop, with associated other clinical problems, including motor, sensory, DTR, and other miscellaneous problems, what you see is that if you take a patient with a deep peroneal nerve problem, you will only have these three. That is the dorsiflexion weakness, sensory loss over the web space, great toe web space, and a Tinel sign. If you look at the common peroneal nerve, you have more. It also involves a foot eversion weakness. Your sensory loss increases and your Tinel sign may or may not be there. When it goes to sciatic nerve, then your motor involvement also increases, including the knee flexion weakness and the foot inversion. And your sensory loss also increases to over the sole of the foot. You also have the lateral part of the calf, and you also have an ankle reflex absent. When it comes to the plexus, it almost involves all the signs, motor and sensory, including involvement of the ankle reflex. And when you have an L5 radiculopathy, it's almost again everything except that the sensory loss over the posterior thigh may not be there, and you may not have an ankle reflex loss. And therefore, this I think is a very, very important slide, which covers the entire clinical features of a foot drop, which will guide you to look at a patient with a foot drop when a patient comes with a foot drop, and then try to localize where the pathology is. Now, a couple of clinical pearls. Sometimes the sciatic neuropathy can present as an isolated common peroneal nerve, sparing the tibial nerve. This is because of the fascicular articulature, where the common peroneal nerve fibers are more superficially located and therefore more prone to injury. So therefore, it may be still sciatic nerve, but it may involve only the common peroneal nerve. So you need to keep a watch out for this. The second one is where the hamstrings are supplied by the common trunk of the sciatic nerve, but the fibers separate much earlier, except for those which supply the short head of the biceps femoris, because they travel along with those fibers which are destined to form the CPN. And therefore, an EMG study of the short head of the biceps femoris can differentiate a true CPN neuropathy from a sciatic neuropathy. And this is something which, if you get foxed by involvement of a biceps femoris, look at the EMG and then you can differentiate this. Sometimes you may get a bilateral foot drop, and these can be the causes of bilateral foot drop, and generally diabetic, peripheral neuropathy, lead neuropathy, vasculitis, hereditary, postoperative anesthesia related paraparesis, etc. Non-neuropathic causes of foot drop include tendon injury, tender Achilles contracture, focal myositis, distal myopathy. You can sometimes get central causes of foot drop, which you must not forget. If you are not able to localize it peripherally, look at the central causes, including parasagittal lesions, anterior cerebral artery infarction. But remember, this may be associated with a subtle deltoid weakness. Cerebral palsy, arachnoiditis, spinal canal stenosis, and a flail leg variant of the amyotrophic lateral sclerosis. Now, how do you diagnose? Diagnosis is first clinical, which is what we are talking about, and then you have the electrophysiology and imaging. I'm just going to touch on that one slide each. So ENG and nerve conduction is an extension. You must use it just to confirm your clinical diagnosis. This is a very busy slide, so just know that you need to do multiple tests to look at what you're trying to look for and where the lesion is. In imaging, you can start from plain X-rays, go on to ultrasound, MRI, MR neurography, and currently neuromuscular ultrasound is becoming more and more important. You also can get neurography using ultrasound. And one of the most important findings which we are looking at now more and more is the problem of an intraneural ganglion of the peroneal nerve as a cause of foot drop, which involves the articular branch of the common peroneal nerve with a retrograde extension of the synovial fluid, and that causes isolated foot drop. So this is a diagrammatic representation of that. But ultimately, clinically, you will have to see where is your diagnosis and then do the appropriate radiology, electrophysiology and radiology to come to a diagnosis. So thank you. This is my presentation. Thank you very much.
Yeah, thank you, Professor Sridhar. Before Professor Suresh,
okay. Or after the quiz only, he has covered everything. And so after the quiz, he is putting quiz in the same thing only. He has
question answer, yeah.
Yes.
Okay, so then after that, I will put in chip in with some comments. Okay.
Yeah.
Because
the questions.
Yeah.
Are you, Veena, are you ready with the questions? And
Yes, sir.
yeah,
So,
can you give the code?
Yes, sir. I will request all the participants to please log in to kahoot.in, www.kahoot.in. Okay, and then I will display the code. So once you key in the code, then you will be able to participate.
Yeah. Do you have a slide of this thing, kahoot.co.in? You may.
I'm just putting in the chat box, sir.
Yeah. Let's all participant means all people who want to participate in the quiz. Please download Kahoot. You don't have to download Kahoot. You have to just type kahoot.co.in.
It is only kahoot.it.
Kahoot.it.
.it, okay.
Kahoot.it, sir.
.it, yeah.
Yeah.
This time we don't have a prize for the winner, but the winner will get a certificate from NSI. But Paritos, is it okay?
Yes.
Okay. So all of you please participate. The top 3 winners will get certificate of appreciation, including the presenters and also the students participating in the case presentation also will get, plus the top 3 who wins the quiz. Please raise your hand once you're ready, at least few of you. Are you ready with the Kahoot? And have you keyed in the code also? Yeah, I am in. Yeah, I got it. Can at least 4 or 5 people tell that they are okay? Then we can start off. Dr. Nataraj has told he has already done it. Dr. Himanshu said he's done. Himanshu, yes. Dr. Mehul, yes. Okay. So people are ready, and he can start off Veena with the presentation. Dr. Sridhar will read out the questions and answer it.
Yes.
Yeah.
So we can see this many people are already logged in.
Yeah, so they'll be logging in. Yeah. More will log in.
Yeah. So there are almost 51 to 52 participants.
Okay. So I think you can start off now. Or how many have already logged in this thing?
29 people have already.
Okay, 29. Others are still.
Ashutosh.
We can start. Yeah, 60% have participated. We can start off, I think.
Okay. So shall I start?
Yeah.
So is the first question.
Yeah, Dr. Chirag, will you read it out or Dr. Sridhar will?
Chirag, do you want to read it out?
I'm just talking with Ashutosh. Just
Okay. Which of the following muscles is an inverter of the foot? So 17, I've got it right, which is tibialis anterior.
So the marks will be allotted on the basis of fastest finger first. Whosoever has given the fastest answer will get the maximum score.
Okay.
Now we move ahead to the next question.
EMG of which muscle helps differentiate a true common peroneal neuropathy from a sciatic neuropathy? So 15 have got the right answer, which is the short head of the biceps femoris.
So the scores after the second question is this.
So Dr. Raghunath is leading.
Yeah.
Yeah.
So foot drop with weakness of hip abduction localizes the lesion to deep peroneal nerve, common peroneal nerve, lumbosacral plexus, L5 radiculopathy. So 19 have got it right, L5 radiculopathy.
Yeah, Dr. Veena, can you please post the code again? People are asking for the code in the chat box. Can you type the code in the chat box for people to have ready reference?
Yes, yes, sir. I'll just stop sharing here and then.
Yeah. In the chat box, I type the code so that people who join later can do it.
Yes, I have shared.
Yeah, done. Okay, next question.
Yeah. Is the fourth question.
Foot drop with absence of ankle jerk localizes the lesion to deep peroneal nerve, common peroneal nerve, sciatic nerve, cortical causes. So 12 have got it right. Sciatic nerve.
Yeah, whoever is G, I don't know, he's leading now. Later we'll ask G to introduce himself. We can unmute G at the means whoever is the topper, we can unmute at that to know that to identify.
Yeah.
Okay, foot drop can seen in all except Hansen's disease, tarsal tunnel, intramuscular injection in the gluteal region, Hunter's canal syndrome. "17 have got it right, which is Hunter's canal syndrome.
Still G is leading. Dr. G.
Okay, G and Dr. Kavin.
Which of the following conditions can lead to central causes of foot drop? Parasagittal meningioma, spinal canal stenosis, anterior cerebral artery infarction, all of the above. So 25 have got it right, all of the above.
Aditya is coming up.
for the student, the faster you give the answer, the score will be higher. So keep in mind. Yes.
Yeah.
So we move on to the next. Yes.
All 10 questions are over?
No, sir. Next question.
Yeah.
This is the 7th.
Identify the incorrect statement about foot drop due to anterior cerebral artery infarction. Associated with extensor plantar, associated with impaired cortical sensation, associated with shoulder abduction weakness, none of the above. None of the above is the correct answer. It is answered correctly by 10.
Murtaza is coming now up among the 3. G is still leading. You should know who is G.
Yes, sir. And the faster you give the answer, you will lead more. The way it's like, yes, sir.
Next question, sir.
Intraneuronal ganglion of the peroneal nerve is due to tear affecting which branch of the common peroneal nerve? Superficial peroneal nerve, deep peroneal nerve, articular branch of the common peroneal nerve, all of the above. "18 have got it correct. Articular branch of the common peroneal nerve.
So yeah, the score, sir.
Yeah. So Murtaza, Aditi, and G are still leading.
Yes.
Chetan and Raghunath are competing with them.
Yes.
So the last 2 questions. Foot drop with weakness of foot inversion, sparing of plantar flexion and eversion, localizes the lesion to deep peroneal nerve, common peroneal nerve, sciatic nerve, L5 radiculopathy. Foot drop with weakness of foot inversion and sparing of plantar flexion and eversion. Mr. Abhishek Acharya seems to be prompting people in the chat box, but only 4 got it right, despite his prompt, which is the L5 radiculopathy.
Yeah, please don't type in the chat box. You do it in your Kahoot app.
Oh, that was a giant leap by
Raghunath.
Dr. Raghunath.
Yeah.
I think that's next is the last question. Sensory supply of the medial aspect of the leg is carried through which of the following nerves? Sural nerve, saphenous nerve, superficial peroneal nerve, deep peroneal nerve. So 21 got it right, saphenous nerve. So whom are we going to congratulate?
We will get it, sir, now.
Mystery man G.
So Raghunathan is.
Raghunath, can you please, Mr. Sridhar, can you unmute Mr. Dr. Raghunath, Dr. Murtaza, and one is
G.
Dr. G. Can you unmute them and they can just introduce themselves?
Yes, sir.
Yeah.
And they can stay because I have to ask them some more questions. Okay.
Yes. Yeah.
Because here already
those 3 plus 2 students will be there for all the questions.
Yeah. Because here
Sridhar
has given the answer, so it is easy for them to pick up. So.
Dr. Murtaza I have unmuted. Dr. Murtaza, I can speak. Whosoever has given the nickname G has to tell me who is Dr. G.
Can you please type in the chat box? No, means what is the in G? Dr. G, please type in chat box. What is your name in the?
Okay, stay quiet. I'm in a meeting.
And Dr. Raghunath?
Yes, sir. Good evening, sir. I'm so excited to be here in the meeting here. I'm a student of, I'm privileged to be a student of Dr. Sridhar and Dr. Suresh Nair, sir. So, so excited to see you back, sir.
So you continue here for 1 hour for the whole session.
Yes,
and
sir.
Dr. Murtaza also, please continue. If you can
Yes,
unshare the screen, we can see all the faces.
Yes, sir.
Yeah.
Dr. Murtaza can also.
Yeah, Murtaza and Dr. G is not, is still not, doesn't want to identify himself or herself.
I think Suchanda is G.
Hello.
Yeah. Okay. Now it's time for me to tell something, or?
Yes. Yeah.
Okay.
Dr. Murtaza and Dr. Raghunath, they can now be visible also, sir.
Okay. Okay. Anyway, congratulations to all three of you. And it's nice, and more I should congratulate Sridhar and his neurology colleague who prepared it so well. But I will just clarify something. Because, you know, inversion of the foot, say Sridhar showed a slide, it is basically by tibialis posterior. It is incorrect. Tibialis anterior also is a inverter of the foot, which is a weak inverter. With inversion of the foot occurs at two synovial joints. One is the subtalar joint between calcaneum and talus. There inversion is occurring because of deep peroneal nerve. And the other is between the mid-tarsal joint. It is between the talus and navicular bone. There the inversion is occurring because of that joint. Inversion is occurring because of posterior tibial nerve. So it is due to both, what as Sridhar correctly told. The component from deep peroneal nerve is a weak inverter. Say a dorsiflexed foot inversion is from deep peroneal nerve. Plantar flexed foot is a strong inverter from posterior tibial nerve. But whatever Sridhar has told is correct. But always you should tell, you can hit also and see which are the muscles inverters of the foot. Tibialis anterior also immediately comes. So both are inverters of the foot. Sridhar correctly told it is a weak inverter. Now, my first question, which is to all three of you or everybody can attempt. Having told all this, now I will start. How will you differentiate L5 root from deep peroneal?
Sir, with hip abduction weakness, sir.
No, forget, you have to tell me from foot examination. Don't go to hip and all. Foot examination you should tell.
The sensory and motor, sir, with foot inversion.
Sensory also leave. Just with other examination you should tell. Sensory you leave, proximal hip muscles you leave. From foot examination, how will you tell? Because I won't waste time, I will just teach and go. Say if you look at L5, what Sridhar correctly told, both will produce foot weakness, foot drop. But severe foot drop will usually come from deep peroneal nerve, because L5 will not produce severe foot drop. But inversion will be severely weak in L5, because you know inverter is L5 root component. While deep peroneal nerve inversion can be weak, it is not normal. Inversion can be weak, but it is more of foot drop than inversion weakness. The other is the other way around. Okay. Now next is little more. I am putting a hypothetical question. One fellow has got L4, L5 root involvement. Both L4 and L5 root is involved. Other fellow has got deep peroneal nerve involvement. How will you differentiate? It becomes little more tricky now. One fellow, because
sensory inversion of the lateral cuff, sir.
What is that?
Sensory inversion of the lateral cuff.
No, sensory, forget. Just tell from your leg examination only. L4, L5, both roots are involved now. L4, L5 from deep peroneal nerve.
Hamstrings involvement, sir.
What is that?
Hamstrings.
Hamstrings, okay, I will give you some little marks, but it is just from foot examination. foot examination, or you can use your knee hammer also.
Ankle jerk, sir.
Ankle jerk, as Sridhar correctly told, it will be preserved only. I am asking deep perennial nerve from L4, L5. Because then once L4 also comes, the foot drop from deep perennial will become more pronounced. Understand? And again, if L4, L5 is involved, the L4, L5 component will make foot drop more pronounced. Previously, what I told is, if L5 is involved, the foot weakness drop will not be that great. Deep perennial nerve palsy is much more foot drop. But if both L4 and L5 comes, that foot drop becomes just like deep perennial. It becomes dense foot drops. And a surgeon who kills L4 and L5 in this surgery should not operate. But how will you differentiate from deep perennial nerve? Because deep perennial nerve, again, other clue which we have told, because L4, deep perennial nerve, we told that inversion can still be reasonably there. But more importantly, what one should do is, just look at the knee jerk. Knee jerk, if L4, L5, it is knee jerk root value is L2, L3, L4. Predominant component is L4. So if you have confusion, just check for knee jerk. Knee jerk will be absent if it is L4, L5 involvement. While it will be preserved in, we are not talking of angle jerk. We are just talking of knee jerk. So if you have confused whether inversion is there, not there, weak, like that, just look for knee jerk. If L4, L5 means knee jerk will not be there. Knee jerk will go. Understand? Now, Sridhar correctly told. Now, how will you differentiate between S1 root and posterior tibial nerve? Which Sridhar missed, but I think he told his allotted time was only for foot drop. S1 from posterior tibial nerve. I will tell the answer, I won't waste time. S1 means three things will go. One is plantar flexion, other is eversion, other is angle jerk. All the three will go in S1 radiculopathy. Plantar flexion, angle jerk, and eversion. While in posterior tibial nerve, one of that will be normal, which is eversion. Eversion is it is a superficial perennial branch of common perennial nerve. So evertars will be normal. So if you have somebody with no angle jerk and plantar flexion weakness, immediately look for eversion. If eversion is involved, it is S1 root. And now, next thing, what Sridhar correctly told, I appreciated, is he told that because mid sciatic nerve can fool you, because the fascicles for common perennial nerve, we can get involved almost sparing the deep posterior tibial nerve component. And he also told that one muscle which we should check, it cannot be checked, only EMG it can be checked. That is a short end of biceps femoris. But in the mid sciatic nerve, this biceps femoris, the long head also gets affected. Some nerve supply goes there. So one can find out whether it is proper sciatic nerve or after it has given branches is, this long head of biceps is a hip abductor and knee flexor. So they can have mild weakness there. Mild weakness of sciatic nerve. Mild weakness, because basically abduction of the hip and extension of the hip is gluteus maximus and gluteus medius. The neurosurgeons, what we are interested is there is a muscle called piriformis muscle. The sciatic nerve can have various, usually it goes under that, but it can have some 4 or 5 different ways it can divide and all. And that's again Sridhar told, the deep perennial component can get involved. Piriformis syndrome is one of the causes of the sciatic pain. You should know what is the relationship between two heads of piriformis, how relationship with sciatic nerve. If it gets involved, usually it is more painful. But if they develop neurological deficit, it is more because of fascicular arrangement. It is the deep perennial component which will get involved. Then, as he told correctly, look for biceps femoris. Okay. He also told very correctly about central causes of foot drop. So he told it is also in the medial medial hemisphere. It can come in the posterior limb of internal capsule. As he told correctly, spinal canal stenosis, everything can, even anterior on cells, amyotrophic lateral sclerosis, they can just involve anterior on cells where there won't be any sensory finding. And always it is, say from lower motor neuron is from anterior on cells onwards. Above that upper motor neuron, always look for exaggerated reflexes, as he also told in accused competition. So let me see, S1 with posterior tibial nerve, I told L5, L5 with deep perennial nerve, we told, mid sciatic, I told L4, L5. I think here we have covered everything. If anybody, so what message I have to tell is L4, L5 from deep perennial nerve. L4, L5, always look for knee jerk. Knee jerk will be, always it will go. While it is a deep perennial nerve, knee jerk will be intact. Because inversion can fool you. Tibialis anterior also is an inverter, but compared to posterior, it is a weak inverter. Because inversion by both these muscles are occurring at different joints. Okay, that is it. Okay, fine. If people have any doubt, just put it on chat box. Okay.
Yes, thank you, sir. Thank you, sir, for that. This thing, and this will be recorded. People can again listen again. I know that by listening once is difficult to assimilate everything. It is available in YouTube. You can listen multiple times to learn all the essence which Professor Nair told us. And so we go to the next session, sir, for the case presentation. Chirag is.
Yes, sir. I'm there.
Other student has not come till now. Okay, fine. No problem.
So the presenter has not come. The Chirag will. You got the presentation now of Dr.
Yes, I got it. Yes, I got it.
So that Chirag will read out his presentation, and then Suresh Nair, Dr. Sridhar will ask questions to Dr. Sourav.
Manas, everybody.
And Suchanda and Paritosh also.
Okay, fine.
So Dr. Sourav, Mehul, Murtaza, and Raghunatham. All of you have to be there to answer.
Answer, and other, everybody has to be there.
All four are there to answer.
We will give prize for that also. If anybody can tell that. The game, I will tell you. Game is very simple. He will tell the history. After the history, you will have to tell the substrates involved from the history. After that, you have to localize to some anatomical structures involved. Based on the substrates, you have to put it into some location, anatomical location. After that, you have to tell the plane of the lesion, whether it is axial or extra-axial. And then if you can tell a pathological diagnosis, it will be fine. That after history, you have to tell. Then after that clinical examination, same thing, and we'll proceed from there. Okay, fine. Start.
Okay. Chirag, can you start?
I'll share. Yes, sir. I'll share. My screen is visible, sir?
Yes, not yet. Share. Yes.
Oh, yes. Good evening, sir. I am presenting case that 50-year-old male. He was right-handed and Hindu religion with resident from Uttar Pradesh, educated up to the graduation and working as a ticket collector. History is given by himself, which is reliable. He was presented with the chief complaint of lower neck pain since last 6 months, clumsiness and weakness in the both hands, and heaviness of the bilateral lower limb since last 6 months. So, a history of presenting illness. Patient was apparently well 6 months back. He noticed pain at lower aspect of the neck, which is insidious in onset, progressive in nature, mild to moderate. It was not affecting daily activity, was present on the wrist only, at present entire day, and now affecting daily activity. Since last few weeks, he noticed severe pain with forward bending of neck, which radiate to both upper limb, spine from the neck, which immediately stopped neutral neck position, so that he stopped wearing the socks and shoes. Now he is taking help of his wife for the same. He also complained of weakness and clumsiness in the both lower limbs, right more than the left, difficulty in holding objects from the right hand, buttoning and unbuttoning, holding spoon while eating, holding pen, change in the writing, and speed too. He noticed is in difficulty in lifting of right upper limb, which affect routine daily activity like grooming, brushing of the teeth. He also complained abnormal muscle movement in the right upper limb muscles. You also complain heaviness of the both legs, which is insidious in onset, asymmetrical and progressive. Noticed more on the right side compared to left side, associated with difficulty in walking, with imbalance, difficulty in lifting of the leg above the ground, leads to the dragging of the right leg, progressive slowing of walking speed. Since last few weeks, whenever he was trying to stand suddenly, he noticed abnormal tremor movement in right leg, which lost for a few seconds and after that stopped itself. He's winning slipper, but wearing slipper, but not the with the conscious mind and paying extra attention on slipper. On inquiry, he said on the procedure of routine blood sampling is less painful, which was painful previously. After a positive complaint, there are no headache, vomiting, and seizure. No history of abnormal sound on the neck movement or upper neck or suboccipital pain. No history of breathing difficulty. No history of double vision, abnormal redness of eye. No history of difficulty in hearing or giddiness. No history of disturbed sleep, change in the voice, difficulty in deglutition, nasal regurgitation of food or nasal intonation of voice. No history of urinary and bowel incontinence. No history of fall or trauma. No significant past history or similar history. Medical history, there was no comorbidity. Personal history, he is vegetarian, sexually active, non-alcoholic. No significant family history present. So, on the summary, 50-year male admitted with complaint of progressive lower limb neck pain since last 6 months. Initially, this was not affecting daily activity, but affecting activity, including his job. He also complained of numbness of both upper limb, difficulty in holding objects, fine movement, and lead change in signature. Also, writing speed below becomes slow. He started from right upper limb, followed by the right lower limb, and left leg and left upper limb. He also complained progressive heaviness in bilateral leg, which leads difficulty in lifting his legs from the ground and affect walking speed too. Now he is not going to his job because of pain, difficulty in fine movement, difficulty in walking, and need assistance all daily activity. So this was summary.
Okay, so you have to. Okay, this is okay. We have got to keep that there. Right? Okay, keep the first slide. Can you show the first slide? Because you know that history part we have to ask what all things he has. Anything more you want in this history? Some of the residents can in the next one. Next slide.
Yes.
You put the next. This is okay. Next one. Yes. Lower back has 6 months duration, clumsiness, heaviness, lower limbs. Next one. Next slide.
Yes.
Yeah. Okay. Okay. Now. So if anything more you want in history, if anybody presents with this is age of the patient is 50 years. He has presented with 6 month history of progressive problem in the limbs, and now he requires help for everything. But you told he is sexually active even now. That is what you are telling. For that he doesn't require any help. No, in spite of bedridden, almost. Like that, I thought what he told is sexually he is still very active. He doesn't have bladder problem. Anything more you want in history? Residents who are there, can you just tell anybody presenting with weakness? You should not just think of trauma.
Any neck pain during the night time, sir?
Yeah, he told there is a patient has got pain in the night time. Something that it was there, no? Get up, let me see. Immediately neutral. Now he is taking help of his wife. Let me see back immediately. Severe pain with forward bending. He was present on rest only, at now present entire day. And also he told it is present in the night time, no? I think I read that.
No, not there.
Not there.
Yeah, yes.
Night time also you told, or was present on rest only. Now it is present at rest also. Entire day. And night time we don't know whether he gets up from sleep with this pain, because he is presenting day, it is there affecting his day-to-day activity. Okay, so before we analyze the pain part, anything in history you want to add more other than trauma or other things?
Sir, about the radiculopathy part, whether there was any
that will come to history of analysis of pain. That will come now. After this, is anything more in history you want? If anybody presents with this is 6 months, it is not a typical of what we see for degenerative spine disease where they have long history. 6 months, patient has virtually requires help for everything. So anything more you want to know in history?
Inflicting events or anything which
like what?
Like any post-traumatic or
trauma he has already told, he has excluded no trauma. Just don't think everything as neurosurgery. There are so many things which can produce myelopathy. Understand? So think of out of the box. You should always tell whether a patient has other things which can produce this type of involvement of the.
Sir, he has ruled out the bulbar palsy also, sir. So it ruled out amyotrophic lateral sclerosis.
Okay, so that he has told. He has told that, no?
Yes, sir. Yes, sir.
Okay, yes, but more than that, what else can produce? Etiology. Which you should, like I will not waste time. So when you get such a patient of myelopathy, which is of short duration, it's a think of something else like non-surgical problems like
B12 deficiency, sir.
Inflammatory, infective conditions. They can come with a short history. It's a infective condition. The inflammatory conditions can be infective, non-infective. So you should think of that. Then exposure to insecticides. They can all produce demyelination of the running tracks in the spinal cord. So exposure to any toxic thing. Then some dal is there. I don't know, kesari dal or something. Which can also, what is that dal? I don't know. So any history of that. So other than history of any history of exposure to toxin, vaccination in the past, viral illnesses. So viral illnesses you should tell in history. No history of, because they can produce acute disseminated encephalomyelitis. So you should tell about any viral illnesses in the past, any say relevant history like exposure to insecticide, in their work where their exposure to their work, any toxins are there, this laterism. So all these things, any history of, they have any immunological illnesses like or inflammatory illnesses in the family or in him, like lupus erythematosus, Sjogren's disease. It is a familial problem. They can all come with inflammatory problems. They can come with short history. Then waxing and waning. This you told it is progressive, waxing and waning, and history of tuberculosis in the past. So all these things you should tell, and then only the history becomes complete. And also you should tell about sexual history also, which you missed, whether patients, erection is normal, because everything has different involvement. We get so much inference, whether erection is normal, where ejaculation, that is both ejaculation has two components, one is proper ejaculation and emission. All these have specific involvement in the spinal cord. So when you can, we will know what is the problem with the patient. So when you tell history, instead of telling the other unwanted things, these things should come. Okay. Now analyze. I'll say one of the resident can analyze now.
Sir, it's a since 6 months history of dull aching pain.
Saurav, where are you from? Saurav?
Sir, Cochin.
Okay, tell me, Saurav. Very good. Yeah.
Sir, 6 months history of dull-aching pain in the neck, which might be because of gradual, can be myofascial initially, and then because probably has taken its course to progress to arthropathy, and then followingly he was progressing to have a myelopathy, sir. So that's what I am thinking.
Okay, please, somebody wanted to ask a question, please.
So, as per the summary of the history, I localize the lesion as a extramedullary lesion, sir.
No, we are not talking of extra. We are telling the pain part you should tell. From where this pain is coming.
Extramedullary lesion, but I'm not sure whether it is intradural or extradural, sir.
Whatever this history is there. Say patient has pain in the lower aspect of the neck, insidious in onset, progressive in nature, and mild to moderate, and it was not affecting daily activity and was present on rest only. That is what present on rest only. That is what, while activity it is there. I don't know. This was a little confusing. It was not affecting.
It is intradural lesion, sir. Intradural.
What present on rest only at present entire day, and now affecting daily activity. So what are the causes of, what are the various types of pain you can get in that location with any pathology? One our person told, one is a mechanical pain, understand? Which he told, myofascial, joint, arthropathy, everything. One is a mechanical pain. The second pain is a radicular pain, understand? Radicular pain. And third is a tract pain. These three pains can confuse you. A patient can have any one of these or none of these, or can have combination of all these. So how will you differentiate a mechanical pain from a radicular pain from a tract pain?
Mechanical pain will be also the neck movements, sir. It will be aggravated the neck movements.
Which one?
Mechanical pain will be exaggerated by the neck movements, sir. With flexion, extension.
Okay, radicular pain also can get exaggerated by neck movements. Say if you move the neck towards the, say suppose a radical is in the pain is involving one upper limb. If you move the neck towards that affected hand, radicular pain will come. That is how we distinguish what is one of the ways of finding out radicular pain. Move the, are you seeing my face also? You move the head towards that affected hand, they get pain. If they get pain along the hand, it is a radicular pain. More than that, what are the characteristics of radicular pain?
Lancinating shooting pain.
It is along it is always
particular nerve root distribution.
It has to come from back and then radiate along the along a dermato. And then anything which raises the intracranial pressure, sneezing, coughing, whatever it is, it will exacerbate the pain. So it has to come from back along a dermatome, and anything which increases raised intracranial pressure like sneezing, coughing, everything, this pain will get aggravated. And your neck movement, that is what I asked you, neck movement towards the affected limb will bring it, as opposed to a mechanical pain. Mechanical pain will not come. I will say if you take your head, suppose you have pain on this side. If you take the head to the opposite side, then the mechanical pain will come on this side. You understand? If you get pain in the same your hand on ipsilateral head tilt, it is suggestive of radical. If you get pain in the same area on head tilt to the opposite side, it is more suggestive of a mechanical pain. What is the characteristic of a mechanical pain? It is a diffuse pain. It can come anywhere in the back of the neck, and everywhere it can go. It can go down to scapular area. It is kind of varying quality, but it can go to any part, behind, back, neck, everything. But catch is, if anybody has, it may not be in any radicular distribution also. What about tract pain?
So burning, dysesthetic pain.
So it is actually a deep-seated pain, very deep-seated pain, a complaint, and it can have varying quality. It is not affected by your cough, sneeze, or anything, and it can present all the time, or it can come and go to disturb you. It can have varying quality, like knife, like, or so many quality it can have, but it is a deep-seated pain, always going down. It will not go up. Understand? So from this history, what do you think this fellow has got? Most of the history is not there, but you should analyze and tell what is the cause of this pain. Severe neck. He also told last few weeks he noticed severe pain with forward bending of the neck, which radiate to bilateral upper limbs and spine from the neck. So what do you understand from that?
There is a severe canal narrowing.
No, I am not hearing. I am not hearing. I am not hearing. Say, if you get, I am not hearing. What is the talk loudly?
Sir, initially the tumor was small to.
No, we don't know what tumor and all. We do not know.
Sorry, sir.
So we do not know what tumor. You tell. My question is, say, what is your inference from this severe pain with forward bending on the neck, which radiates
anterior compression?
If you have severe pain radiating along the back of the spine or neck flexion, what do you call?
Dermat signs.
But this fellow has got a severe pain, forward bending of the neck with which radiate to bilateral upper limbs. But that is a vague statement. Bilateral upper limb, you should tell where exactly it is radiating. And any pain which radiates to bilateral at the same time, it cannot be a radicular pain. And the spine from the neck, probably it is from stretching, as you told correctly, from dural stretching, only this is occurring. Okay. Just immediately stop in neutral position. Absolutely correct. Okay, that it is coming because, spinal cord length increases, dural stretch occurs when patient is in flexion. Okay. Okay. So what is the next one? So that he stopped wearing
socks and shoes.
Socks.
They have written here also. History suggestive of Lehermann's phenomenon. Okay. Now he is taking help of his wife for the same. Okay. So whenever he bends down to remove the socks or put the socks, he gets severe pain along the back and along the hand. Okay. It is suggestive of Lehermann's phenomenon only. Okay. So, one thing we have analyzed, this pain is not a radicular pain. Understand? It is very likely it is after examination only we can tell whether it's a mechanical pain or radicular pain, but we'll see after examination. But it looks like more like a tract pain to me. I don't know, because of this phenomenon. Okay, next thing, next slide. My other colleagues are there. They can ask some questions. Sridhar and Sridhar is there. Sridhar, you can chip in with one or two questions.
Suresh, I have to leave now because there is a function I have to go to. I have actually come out. So you please carry on. You have even taught me. So you are the best teacher.
No, what you are talking. Oh, okay, Sridhar. Thanks for that.
Thanks.
Okay. So Manas and Suchanda and Paritosh are there. They can ask one or two questions before we analyze the next symptom.
We'll analyze, sir. We'll take it at the end.
Okay. Next one. Next slide.
Yes, sir.
Yeah. Next slide. Okay. Just that one student is there. He has to tell what is this actually. Please, one of you can tell. Yeah.
Right upper limb water weakness.
Where it is more, you should tell.
So it's a right
proximal right shoulders.
It's distal to proximal involvement, sir. It is extending from distal initially and then to proximal, more into the right side. So it's a yeah, that's all. It's involvement of the corticospinal tract, or the nerve, or the anterior hornsel or the nerve root. We don't know yet, according to the history.
It started from proximal to distal, sir.
Yeah.
Distal to
anybody want to, there are so many other students are there, they can also tell. This is involvement of what? Somebody told it is involvement of anterior cell. Somebody is telling involvement of pyramidal tract. So what do you think this is from? The more it is a distal involvement, no? Let's say buttoning, unbuttoning, holding pen, changing. So such a thing, distal is more for dexterity. It starts with dexterity, which is a classical thing of a pyramidal tract involvement. Very unlikely from an anterior cell, no? Okay, it looks like that, understand? But later he started having proximal weakness also, lifting upper limb, all 6 months duration. These things have started in 3 months, okay. And he also complains of abnormal muscle movement. That is, I think, twitching, no? Twitching movement in the right upper limb. That is the of what actually?
Upper motor neuron, really.
Upper motor neuron, any twitching?
Lower motor neuron, sir.
Lower motor neuron, sorry. Okay.
So the anatomical substrate for this is what actually? Anatomical
anterior horn cells.
You think it is anterior horn cell because of this flickering movement, right?
Or the nerve roots, sir. Both can be element. In anterior horn cell involvement, there will be florid fasciculations. So it will be very prominent.
Okay. So I take it if he has got twitching and all, there is an element of lower motor neuron also. Next one, next slide. Okay, read this.
He also complained of heaviness of both the legs, which is insidious in onset, asymmetrical, progressive, associated with difficulty in walking with imbalance, difficulty in lifting the leg above the ground, legs, dragging of the legs, progressive slowing of the walking speed. Since last few.
Okay, so that is suggestive of what actually?
It is
foot drops, right? Foot drop.
What is that?
Right foot drops.
Right foot drop.
So it can be spastic gait.
The foot drop, no. It is, you know, why foot drop should have patient should have problem in getting up from somewhere. Difficulty in lifting of leg above the ground. Agreed, distal weakness is there. But also patient has difficulty in walking, stiffness, heaviness. Heaviness means stiffness, understand?
Hip flexion and right foot drops. Hip flexion and right.
Distal weakness is there. Difficulty in lifting of leg above the ground, leads dragging of the right leg, progressive slowing of walk. So it is suggestive of what?
Hip flexion and right tibialis anterior weakness, sir.
What is anatomical substrate for producing this problem? Is it lower motor neuron or upper motor neuron?
Upper motor.
Upper motor.
Upper motor. It looks like, you know, both legs. No?
Yes, sir.
Say both legs, you know, you will never have a bilateral lower motor neuron coming immediately. But Sridhar told one very few examples like that. Usually it is not the case. So both legs and heaviness. Heaviness means in many people tell instead of stiffness, they tell heaviness only. So it shows it is not lower motor neuron, it is upper motor neuron problem only. Okay. Now this one, can you read this?
Can I tell something, sir? Means for the students.
Yeah, please. Yeah.
No, it's when you present, it's always better to tell difficulty in clearing the foot from the ground rather than difficulty in lifting the leg. Means lifting the leg, when you tell people think it's an element like a foot drop. So you know that we are presenting a case of spasticity. So this patient has difficulty in clearing the foot from the ground. That will not create any confusion.
Absolutely correct. That is the correct thing which should have been told. Okay. And also since the last few weeks, can you read? Chirag, who is reading?
Yes, sir. Since last few weeks, whenever he was trying to stand, suddenly he noticed abnormal tremor movement in the right leg, which last for the few seconds, and after that stop itself.
So what is that? That the candidate can tell. What is it?
Clonus.
It is a spontaneous clonus. Okay, and then
he is wearing the slipper, but with the conscious mind and paying extra attention on the slipper. On inquiry, he said on the procedure of routine blood sampling is less painful, which was painful previously.
I didn't understand. What is that? blood sampling means somebody was taking blood from him.
Decreased pain sensation, sir.
Decrease the pain sensation.
Where actually? Where is this pain sensation?
From the hand.
No, why drew the sample from the leg?
Blood sampling is less painful. Where, in the leg or in the hand, or where it is?
Most probably hand, sir.
And
But suddenly he has come from leg to the hand, Okay, so what does this suggest?
posterior column involvement, sir.
Posterior column, sir. Proprioception.
Is weaning, whatever. Is
Typographical errors.
Wearing.
Okay, with the conscious mind and paying extra attention on slippers. I didn't understand the meaning of this. What is weaning slippers?
Wearing, sir. Typographical error, maybe.
Sir, can be due to the spasticity.
It looks like it is from distal weakness only, because of spasticity only. Okay, difficulty in wearing slippers, or slippers can come out. When he walks, the slipper can come out also. Okay, this we'll see later. I am not very sure. Next slide.
That also.
No. Put that. So here I told many of the things you should tell. Many other things you should tell. Negative history, which is of importance. So which negative history or cranial nerve history you have to tell?
Low cranial weakness.
Facial sensation, sir. Fifth nerve sensation.
Sensation, dysphagia and regurgitation.
What is that? They say if you have now a patient has got some cervical area is what we are having, but which cranial nerves we will try to get a history whether it is involved.
Lower cranial nerves.
Lower cranial nerve.
Lower cranial nerves is a huge thing, man.
5th and 11th.
Phrenic nerve, sir. Diaphragm. Phrenic nerve.
Phrenic nerve is not a lower cranial nerve, man. So
cervical case, sir.
The accessory nerves, sir. Accessory nerve and
trigeminal nerve. And spinal
so you want to look for, so you will ask for, specifically you will ask for symptom of spinal accessory. What symptom will you ask for?
Shoulder shrugging, sir, and
very good. So drooping of the shoulder. Shrugging all we will examine only. So any drooping of the shoulder is there. Okay, then what else? What cranial nerves? So one you told spinal accessory, then?
Sir, and then again, hypoglossal nerves, the tongue wasting, sir.
Okay, you can ask about any, what is that specific thing you will ask for palatal weakness or tongue weakness and lip, la, like that, any problem with phonation, understand? Yes, so la comes from tongue only. Okay, so you can ask for any wasting, twitching, other things. You should tell in negative history all this. Patient doesn't have any wasting or weakness in the tongue and no difficulty in telling words. Okay, and then so you were told about 12th and spinal accessory and accessory. What else will you ask for?
Hearing, sir. Hearing and
trigeminal.
Hearing and usually will not get affected. No, you should tell what will get affected, which cranial nerves can get affected. Once somebody told, the trigeminal
nucleus of the trigeminal nerve.
Yeah, absolutely. Trigeminal, the descending tract, the nucleus, they can come low down. Nucleus, it has got that, that oralis, interpolaris, and caudalis, they have specific distribution. So if caudalis is involved, they will have some sensations which will come from outer. Understand? Inner part. So you should ask whether they have any sensory thing over the face coming from out. You should ask in history. So examiner knows you are looking for something. Then what other cranial nerve you will look with interest?
Glossopharyngeal and vagus.
Usually it can, I won't disagree because, some CV junction with pathologists can produce traction of the, especially if the tonsils are very large, it can, and brainstem has come down, it can drag the nerves, but usually it is very rare. So 9th, 10th and all.
As per literature, 8th nerve is more commonly involved in CV.
Yeah, well, correct. Only 8th nerve very, for some bony anomaly and all, it can get involved. But what other cranial nerve you are interested more? Anything in the eye, And what symptom you should ask for that?
Look for downbeat nystagmus.
So they can have what? They can have downbeat. So what history you will ask? What is
double vision during climbing down?
Not double vision. Say the jumping of when they look like that, that thing they jump like that. If they have this downbeat nystagmus, when they look to side, usually it is primary position, but more getting aggravated on looking to down. So if they feel everything is jumping, that history you should ask. Understand? So cranial nerve history you should ask. So let me ask: headache, vomiting, seizure, no history of abnormal sound. That's a good history. Breathing difficulty always you should ask. Understand? No double vision, abnormal redness. That is, I don't know. History of hearing, then history of disturbed sleep, change in voice, deglutition, regurgitation. No history of urinary and bowel. In spite of all this, patient doesn't have any urgency of micturition, nothing, no hesitancy, urgency, precipitancy, he doesn't have, no?
Yes, sir.
So what you would have expected in this patient with eye problem? If there is any involvement of the cord between pondine micturition center and our spinal center S2, 3, 4, what symptoms can occur?
Urge incontinence, sir.
What is that? You should ask leading questions. Leading questions whether
increased frequency and poor emptying of bladder, sir.
Complete wording.
Okay, poor emptying. Okay, so you should ask for increased frequency. Usually, increased frequency, precipitancy, or is more from uninhibited bladder. Here they will have what more they will have.
Detrusor overactivity.
It is actually detrusor. And sympathetic, parasympathetic dysenergia. They act just opposite. So if one contracts the sphincter, detrusor contracts, sphincter should relax, and vice versa. One is relaxation is by sympathetic and constriction is by parasympathetic. So you should ask what will happen if cord is involved, what they will get. Cord is getting involved. What urinary symptoms they will get.
Increased frequency, sir. Increased urge incontinence.
Yeah. They will have urgency. Understand? Urgency of micturition. Understand? And next symptom, this one. Next slide. We have to proceed. Yes. We are already 8:45. Next,
Getting. No medical history or no past.
The medical history, so many things I have told you, all those things you should ask in history. Yes. History is, I told about, that some kesari dal or some dal eating, any exposure to toxins, any history of vaccination, exanthematous fever, any history of any inflammatory illness in the family history like that. So these things they should tell, because the examiner knows you are not only looking at all the tumor and trauma, but it can be a vascular cause, or it could be a infective, inflammatory, so many degenerative illnesses like medical problems. They can have the degenerative of the tracts also. Understand?
He specifically mentioned vegetarian, sir.
What is that?
He specifically mentioned vegetarian.
Yeah, okay, vegetarian is told. Okay, fine. B12. Okay, agreed. Okay, next slide.
It's summarizing, sir.
Okay, can you read, and then one of you should tell the anatomical substrates involved and tell me where you can localize. One of you can vouch and tell, because we are already 8:50. So we are already running out of time. Please make it fast. You tell, no, don't read. You tell the anatomical substrates involved. Can you tell what is involved from here?
Yes, sir. So it is corticospinal.
Next slide. Next slide. Yeah. Okay. So he has already written. So corticospinal tract, as evidenced by what? He has written at C5.
Both upper limbs and spasticity in both lower limbs, sir.
The corticospinal tract is definitely involved. Understand?
Yes, sir.
So he has written at C5. He has localized also.
Yes, sir.
Because he is not getting anything involvement above C5. Because we didn't get any of the cranial nerve or breathing difficulties. So he is localizing.
Predominantly small muscles of the hand, sir.
And that he has told also. If patient has got some involvement.
So C5 spinal cord has a C6, C7 cord segment, sir. I guess.
No, we do not know as of now whether it is a segment of the cord is producing this.
C5 level, the cord which is supplying the hands or in the location located over the C5 level, sir. So I thought C5 level cord is affected. As far as corticospinal tract, we should produce the clumsiness of both hands.
I agreed. So I agreed, but is there anything, because if there is wasting and if there is fasciculation and all, you have to put LMN also. But he has put it in the radicals only. Okay, which may or may be still in the cord only, at the anterior rods only. And so what is there for involvement of dorsal column and spinothalamic tract in this patient?
Lermite sign is there and loss of pain while the needle break is.
Okay. So that is why he has put. So why he has put tract?
So crossed.
What is that? Why tract, man? Is it from tract or somewhere else? Is it a suspended loss in some hand or it is all of one side?
So predominantly asymmetrical, sir, on the right side. So it should be. Maybe
no, where is this? He told some he is not appreciating pain. I don't know, while somebody is drawing blood from one hand,
Yes, sir.
That is only confined to one hand only,
Yes, sir. Yes, sir.
Yes, sir.
Possibly right hand, sir. Possibly right.
So if it is confined to one hand, so what is anatomical substrate for that?
Contralateral.
Maybe right side hand or
the tract. If it is
anatomical tract, it crosses. It crosses across over 4 or 5 segments.
Who is this telling? Raghunathan? Who is telling this answer? Raghunathan.
Yes, sir.
Raghunathan, if you say what is the cause of that isolated involvement of loss of pain sensation in one hand? That is what is the anatomical substrate for that? Is it tract or something else? I agree, it could be spinothalamic. Spinothalamic, it has not crossed and become the tract. It is somewhere in the crossing stage only, in the ventral commissure. Understand? Okay. So there, this fibers from to pain temperature fibers for that particular part is getting involved. Probably, we don't know. Or it could be from a radical involvement also. We don't know. A radical involvement can also produce the same problem. But if you think root, there is no involvement. Say it is crossing fibers only. Understand? It is not tract. Once tract means it has already crossed the whole one side should go. This we have told also. Lehermit sign. So this is the substrate involved, probably crossing fibers or radical involvement. Because radical involvement, they will have root involvement or they will have sensory loss. We are not sure. But we are not sure whether these roots are involved, whether it is the segment of the cord anterior or we definitely know that corticospinal tract is involved. And we know that this we presume it is crossing fibers and not roots. And this we know Lehermit sign it is there. So if these are the anatomical substrates, where do you put the lesion? And somebody told he is putting the lesion at C5 level. Understand? That is what he has written, no?
Yes, sir.
So how do you say you will have a sensory level, you can have a motor level, you can have reflex level, or that we have not examined.
Yes,
so which one you take as your level? Now, somebody has sensation, he is telling, I have got sensory problem in the back of the neck. Somebody is telling, I have mild weakness of the shoulder. So where will you take your level now?
C5, sir. C5 or
C5. C5 is the motor you are telling. It can, because in C5 you cannot tell the upper level of involvement is weakness of the proximal muscles. You know, it is upper motor neuron only. We do not know. So we are putting from the motor examination, it is C5. But that fellow was telling pain somewhere back, everything, no? So its sensory level could be high up. So if you have somebody with the different sensory levels in history, where will you put your clinical level? When it is always the highest, whichever is highest. If sensory level is the highest, you take it as your clinical level. If motor level is highest, if motor level is, somebody is telling I have numbness below the nipple level, and that level is D4. So don't take it as a level, take this C5 as your level. Somebody is telling reflex level that we have not examined. So after that, if reflex level is highest up, you take that as your level. If your autonomic level is highest, you take that as your level. Understand? So here now, as of now, we presume it is something at C5 level. So what do you think it is, and what is the plane of the lesion?
Intradural extramedullarism.
Why you are telling intradural extramedullary, man?
Pain at rest, sir.
And pain at rest means it should be intradural.
Initially, it was pain at rest, and then it is aggravated by the neck movements in the later stage.
Why cannot be it just an extradural lesion?
Yes, sir.
Sir,
Neck movement.
it could not explain the.
Go for extraaxial.
What is that? The talk loudly.
Pain at neck movement will go for extraaxial lesion.
Pain and
movement, sir. While daily activity.
Yeah. So this is what Mehul you are telling. So
yes,
Solanki, you are telling you think it is an extra
axial, sir.
Extradural lesion.
Extradural lesion, sir.
So the person who told intradural, so how will you differentiate extradural from intradural from history?
Sir, first complaint was radicular pain over the right upper limb. So which denotes that the involvement was.
Somebody has written the answer also.
Asymmetrical.
Somebody is writing the correct answer down for everybody. So I don't know. Mrudal, who is written here? Pain, tenderness, symmetry is suggestive of extradural. Yeah, somebody has written the correct answer. Say it is bilaterally symmetrical thing, and pain. Bilateral, it is more suggestive of extradural pathology. And okay. So what do you think it is actually? What is the, if you can tell the etiology for this, what do you think it is?
The short duration, sir, 6 months.
Old age with
what old age? And 50 years only.
Short duration, sir, progressive weakness. It more suggestive of a neoplastic etiology, sir.
This person is always stuck with Raghunath. Always here, unless you know the case. If you know the case, you should not tell, man. Otherwise, don't tell neoplastic. Exam, you should immediately withdraw, man. Something which you should not. No, somebody has told. So, if it is a neoplastic, you have been telling intradural extramedullary.
No, sir.
So what type of involvement they will have? Somebody wrote and told you also, no?
No,
they
sir.
will have asymmetry. Understand?
I'm blind, sir. I'm blind.
And then why are you keep on telling all this intradural extramedullary?
Asymmetrical, sir. A night pain at rest and the short elderly 50 years old male with gradually progressive weakness and without waxing and waning history.
Gradually 6 months were relatively fast only.
Yes, sir, relatively fast. That was I meant to say, sir. Relatively fast. So very unlikely to be due to the extradural, sir, where it is waxing and waning will be there.
I will put my cards because of bilateral symmetry. Somebody told also bilateral involvement and very gross involvement. Usually it will not come with, I have not seen a intradural extramedullary tumor coming with gross spasticity with so much wasting and all. Very, very unusual. Understand? Intradural extramedullary lesion coming like that in 6 months' time. It is very unusual. Okay, we'll go to, what about Paritosh and Suchanda? They can put in something.
Sir, listening to you, sir, you are covering almost everything.
So we will go to examination. Come quickly. We will go to examination.
Yes, sir.
Please fast. Yeah. Examination, can you tell? Yeah. Vertebral level, cord level.
That was.
Go back. Somebody has written that also. Extra-axial lesion, extradural lesion, compressive lesion. So let me tell you, say he has put compressive lesion. Why? How will you tell compressive or non-compressive?
So both the corticospinal as well as the dorsal column are involved. Both are highly myelinated long tracts. So
very good, man. But you know, how do you know dorsal column is involved? Only that symptom is there, no? We do not know.
Yes, sir. And walking. Yes.
We are not sure. We are not sure as of now. Understand? Compressive or not, because you know there is spinocerebellar ataxic syndromes are there where both pyramidal tract can get involved, posterior column can get involved. So there are medical conditions which can come with non-compressive, which can get involvement, both can come. Understand? But usually not. Understand? So next slide. This is examination, or what is it?
No, sir. It was, he has mentioned it by himself that his localization, Dr. Ashutosh.
Okay, yes. Okay. Can you just show that? Cervical myeloradiculopathy with involvement of corticospinal, spinothalamic tract. You should not commit this mistake there. Tract only, not track. Track is in the our rail only, you know.
Yes.
This is okay. Come, tell this. Okay, patient is read. Somebody read.
Yes, sir. On examination, on general exam, patient is well behaved, cooperative, well dressed and lying on the bed. No pallor, no icterus, no edema, and no generalized sign.
Go back. What is this one? I didn't understand. What is this one? What is the meaning of this?
Not sir.
Is a word like that? I have not heard. I don't know. Okay, lymphedema. Okay, next is me.
Is there colonychia? Something with the nails? The nails become brittle.
Okay.
On systemic examination, RS exam movement is bilateral equal. Respiratory system symmetrical, air entry in the both lungs. CVS examination normal. Abdominal examination soft, non-tender. On CNS examination, high mental function was normal. On cranial nerve examination, is able to smell.
These things we skip, you know, unnecessary things we should not tell.
Yes, on cranial nerve examination,
no mistakes. Okay, next. This is also he is telling everything is normal. Okay, next.
Facial hearing is intact.
Next.
Local examination on inspection on local no localized swelling, any discharge, redness or deformity. On no swelling, rise in tenderness, deformity.
Okay, go. Okay.
Bilateral neck movement is restricted. Right side more than the left. Forward flexion give pain in both upper limb. Single breath count was 15 and breath holding time was 16 seconds.
That Sperling sign, you know what is Sperling sign?
Sir, on flexing of the neck to the ipsilateral side,
he has not written neck movement restricted, right? more than left. Neck movement is restricted. What neck movement is restricted? I don't know. It is rotation, flexion, forward flexion, give pain in bilateral. So when you talk, you should talk of all the movements, lateral flexion, rotation, flexion, extension, which is not, we do not know. This is
correct.
Breath holding time 16 seconds. This is single
breath count.
Okay. Okay, next.
On motor examination, on nutrition, like muscle wasting was there on bilateral thinner muscle, right side more than the left. Tone, there was grade 4 modified Ashutosh scale, increase in the all 4 limbs. Well sustained bilateral knee and ankle close.
We know that. So it is grade 4 weakness. Distally, it is weak only. It is not there. It is weak. Yes. So he should write properly. Otherwise, it will like the track only he has put here. So distal more involved. Otherwise, so whenever you tell about power, it is this has no meaning. Actually, yes. You should tell whether there is differential weakness between flexors and extensors in the upper and lower limb. Understand? If it is a pyramidal weakness, in the upper limb, extensors are more involved than flexors. That would have given us some thing. This is just like MBBS student telling only. Okay. So you should always tell lower limb, it is usually flexors more than extensors. Some people tell anti-gravity muscles are more involved. It is not correct. Understand? Because in the upper limb, even if extensors are more than one of the anti-gravity muscle is the latissimus dorsi and pectoralis, which is actually a flexor muscle. So it won't go always. But extensors are more involved. What I am telling is anti-gravity muscles may not be involved. It may not be all the time in the upper and lower limb flexor or extensor, but upper limb basically it is extensor. If he has written like that, we could have got some information. Next one.
1 minute.
Deep tendon.
Suchanda wants to tell something.
Yeah. Sir, I always have this thing in mind and wanted to clarify from you. When we have stones to the level of grade 4 with both clonus, stone to the level of grade 4, and that kind of weakness, does it make any difference?
Suchanda, can you come closer to your computer?
Okay. Okay, sir. What I'm saying is, 1 minute.
Say if the tone is more, can you correctly assess the power? That is what you are telling.
Yes.
That is what you are telling, no?
Yes, sir. Yes.
Oh, difficult. I agree with you. It will be difficult. But, everybody should know how to examine the tone. Suppose, I want to examine the tone of my bicep. So you ask me to flex like that. You are seeing me, no? Suppose I want the tone of my biceps. I say I keep it like that, extended like that, and then you do like this, or you do like this. What do you do? Say always from the contracted position only you should try to.
Yes.
Contracted position only you should examine the tone. It should not be in the direction of that action of the muscle. It should be contracted position, check like that. Okay. Next is right. Next slide.
Yes, sir. Getting it. Yeah. Deep tendon reflexes examination, sir.
Okay. Okay. No need. When everything is exaggerated.
Yes, sir.
Okay.
Babinski sign that was plantar was bilateral flexion.
Very difficult, man. With this 4+ and 5+, the neighboring patient also plantar will go up, man. It is so.
So what is 4+ are for biceps and triceps?
Yeah, everything. And he is telling it is.
4+.
Babinski has put signs. That means,
that is wrong, sir.
That also is wrong. You should not. Yes. Okay, gait, wide way, spastic gait. But we know it is exaggerated, hyper exaggerated. Okay, next.
Romberg's test was positive and tandem walking was swaying on the right side.
Very difficult. Now, if Romberg's is positive, it's very difficult now to do this also. No? Okay.
Yes.
Next. Okay. No. So radiology don't go.
Yes,
so what about sensory system they have swallowed? He told some pinprick is not there and also that is totally swallowed. And also autonomics, these things.
Yeah, sir. He has missed it.
Sensory he has missed actually.
Yes.
Actually, from next time we would like to see what they are presenting because it is seen by so many people, no? Yes. So what I am telling is, I say reflex level, sensory level, motor level, all the 4 levels, autonomic level, all the 4 levels you should check. Here now we have the highest reflex. We know it is biceps is exaggerated. So above that we do know there are other reflexes above also. And autonomic level, what you test is, one needle you take and just scratch like that. Usually you get that wheel, everything, and that redness will come. At some point of time, if there is an autonomic level, that thing will go. So you can keep it as the, don't scratch from below down and come. Now it is biceps is exaggerated. So you start scratching from somewhere there. It is to find the highest level. Scratch from there where that wheel, those things disappear. Then that is your autonomic level. Reflex level we have. Motor, level he has written proximal muscle some grade 4. That much we know. Understand? Sensory level he has not told also. So whichever highest you are getting is your level. So what is your diagnosis now based on anatomical localization remains same. Structures involved, substrates involved are same. Anatomical localization we know it is above C5. It is not C5 now. Now we know it is not C5. Previously we were not sure because motor weakness they told it is upper shoulder is affected. Now since the reflexes are exaggerated, we know that it is going up. So you have your motor level is above, your clinical level is above C5. Other things we have no autonomic level, we do not know, we do not have a sensory level. And always you should check for neck flexion, neck extension, those power also you should tell because it also has some value. Trapezius weakness, sternocleidomastoid weakness, because they get supply from cervical cord also. And also diaphragm involvement. And so that can give you a localization above C5. So trapezius weakness, sternocleidomastoid weakness, and diaphragm weakness you should tell. But as of now, in this case, we do not know. We know it is above C5. So our localization is above C5. Pathology, what you are thinking, same pathology. If somebody was telling tumor, that person wants to tell now tumor or something else. It is bilateral.
No, sir. Now, because the neck movement restriction is there, and the more predominant small muscle wasting in hands, localized to extradural lesion above C5, high cervical cord lesion, sir. Below the cervical medullary junction and above C5.
No, small muscles, why you are telling it is not high cervical? Why you are telling small muscles of the hand? See, here again you are telling a wrong answer. Your localization you are telling based on small muscle and all. I am telling it is some cervicomedullary lesion you are telling. Extradural lesion. Why you are telling localizing it based on a small muscle wasting, man? You are correct, man. So small muscle wasting can occur with a high cervical lesion. Understand? You should immediately tell. It is, you can explain small muscle wasting because of say various pathogenesis is there for small muscle wasting with high cervical lesion, high cervical lesion.
Venous congestion.
But what are the telltale evidence in if you if you want, if I ask you what are the few telltale evidence to tell the patient has got a cervicomedullary area problem. Of course, if you know muscle weakness and all, you can localize. Now you are taking it very high up.
Single breath count, sir. Respiratory muscle weakness, sir.
10 features you tell. Okay, somebody can start.
Single breath count and
single breath count can come from anybody with C2, 3, 4, all 3, 4, 5. They can have single breath count problem. I am taking it above.
So downbeat nystagmus.
One is downbeat nystagmus. Okay.
Okay.
Sir, and if there, sir, post-acid headache. Post-acid headache.
What is that?
Post-acid headache.
No, an examination finding on examining a patient.
Facial sensation patterns.
What is that?
Facial sensation, trigeminal nucleus.
Vaguely, you should not tell, man. Trigeminal, what sensation, man? You should not talk like a MBBS entry student, man.
Perioral, sir. Perioral.
Perioral sensory loss, eh?
Yes, sir.
No, man. Perioral will be spared, man. It is usually coming from out. Understand? Okay.
Cruciate paralysis will be there, sir.
Okay, somebody told, who told cruciate paralysis? Correct. Cruciate paralysis. You should know how it occurs. Okay. You should know how upper limb pyramidal fibers, they cross. Lower limb crosses later. So crossed fibers will be in touch with the uncrossed lower limb fibers. Understand? So they have ipsilateral upper limb and contralateral lower limb. Okay. Cruciate then.
So
iceberg.
Then Ellsberg phenomenon
that can occur with anything, man.
With
Any compressive lesion can occur. Understand? Below also. Elsewhere can occur with any lesion, man. Your cervical spondylosis also can produce that.
Someone has written balaclava helmet distribution.
Correct. That is what that balaclava helmet is trigeminal. That the onion peeling like that. It comes like that. Okay. Outwards, inwards. It comes like that. This area will be said. Okay. The cruciate paralysis, then
wasting of the paraspinal muscles.
Whereas,
I mean, in the suboccipital muscles.
Absolutely correct. Suboccipital muscle wasting and C2 hyposthesia. Understand? Two more findings we got. Okay. Then
low cranial involvement, sir, or
spinal accessory involvement. Correct. Spinal accessory involvement is suggestive of could be suggestive of CV junction. Understand? And even tongue involvement also. Agreed. That downbeat nystagmus. Anything else?
Nystagmus, sir, downbeat.
Torticollis.
What is that?
Nystagmus, sir, downbeat nystagmus.
That somebody told initially, man. Don't tell again. What is
Torticollis.
Torticollis can come with cervical spondylosis also, man.
Hand muscle wasting, sir.
That initially somebody told, we told that hand muscle wasting. We started with that, no? Then
mirror movement.
Bladder.
Somebody told. Who told mirror movement?
I said, Dr. Chirag.
Okay, you told mirror movement. Then say if we have posterior column lamination, it is upper limb fibers are lateral and what is it? The lower limb fibers are medial. Understand? Lamination. So if we have somebody who has got preferential posterior column involvement in the upper limb with spared lower limb, it is more suggestive of a CV junction. You understood?
Yes.
But that is because of lamination. Upper limb will be more lateral. They get involved. But posterior, you check for all these posterior column sensations, it will be normal in the lower limb. If you have somebody like that, it is also suggestive. So then you have these telltale markers, low hairline, short neck. Those things also you can tell. Understand? So all these things you should tell. If these things are there, it is definitely somewhere in the CV junction. In the absence of that, you should go by all this localization only. Understand?
Yes.
Yes.
Okay. So anyway, the clinical examination was incomplete only. We are not sure. So we know something is there which is above C5. Understand? So another thing, what is described, which I cannot know. I don't know the explanation for that. If suppose somebody has got pectoralis reflex exaggerated, it is suggestive of
above C4 involvement.
It is C234, that involvement. It will not occur, even though pectoralis major supply comes from C6. Say that if you have a cervical spondylotic myelopathy at C5, they will not have this pectoralis reflex exaggerated. But if suppose there is a problem at 3, 4, 5, sorry, 2, 3, 4 high, they can have an exaggerated pectoralis reflex, and also they will have other exaggerated reflexes. But a lesion at C5 and down, they will not have this. Okay. So sensory examination, we told, okay. So our pathology remains same, no? Okay. Now radiology you show. How many more minutes we have?
10 minutes.
10
Only.
minutes.
Okay, Paritosh has put 10 minutes. Okay, radiology, come quickly. Okay.
This is cervical spine lateral view of X-ray, extension and flexion view, sir.
Yeah. Okay, tell what is one. It is okay or you
Straightening of the.
This is loss of cervical lordosis.
What is that?
No, cervical straightening, sir. Cervical spine straightening.
No, this is
So
actually extension flexion film. It's not a neutral.
Yes,
film.
flexion extension. Yes, sir. Yes, sir.
So you cannot tell about you cannot come in. You should tell about other things only, you know.
This is a lateral.
Reduced space with the osteophytes.
This is a lateral X-ray view of the cervical spine, which is in extension position. If you will see the vertebral size, you can just make out that at the level of C4, C5, the size of the vertebra is reduced compared to other vertebra. There is the anterior spinal line. There is the osteophytes at the level of C4-5, C5-6, and C6-7. The posterior line, there is a hyperintensity just behind the vertebra. We can see it each and every level. And compared to 3, 4, 5, 6. So spinolaminar line is almost in the normal position. The dens, it's with the C1 arch is in the normal position. Other thing is there is a definite the narrowing between the posterior spinal line and the spinolaminar line. There is a narrowing at the level, and there is the foramen is visible at the C6, C7, and there is other foramen is not correctly visible. There is no listhesis. There is no displacement of the vertebra, and is there. There is no fracture.
What is the normal canal diameter at 3, 5, and 7? Can you tell roughly?
10 to 13 millimeters, sir.
No, that is a normal I am talking about. So when you tell, you look at the canal, and if you tell C5, roughly 15 point something, man. Roughly, that is the median.
Yes.
So little lower down, so you should 15 you keep it, you know it is okay. Understand?
Yes, yes.
Above up it is little more, man, 17 and all. Understand? Yeah. What is it? Hello? Suchanda, you can tell.
Yeah, no, at C2 it is 19, and then at C3 I think 17 something.
17 and the C5 15 point something like that. So you have measurements for that. Okay. And you to talk always of the C1, C2 in flexion picture. Extension is if there is a reducible problem, we will not make it. Here yes. You should tell between odontoid and arch of atlas. Understand?
Yes.
Is it okay here?
Yes, sir. Odontoid is okay, sir. Position is okay.
The other picture, flexion picture, you should tell. Flexion.
Yes, sir. Odontoid is looking in the normal position. There is predental space is also looking normal, sir. And no significant displacement of the vertebral body or any dislocation.
Okay. Okay. Next picture.
This is X-ray of same patient, flexion extension, because
yes, sir.
The dental implants, some implants are seen here, not seen.
Where?
Okay.
That
okay,
is flexion, so it is might be
missed out. Huh? Okay.
Yes. Yes.
Okay.
This is neutral position, sir.
Okay, here you should tell about the lordosis. There only. So I think lordosis is main. For a 50-year-old fellow, some osteopathies are there. Okay. Here canal looks okay. Here, as you said correctly, canal is looking tight only. Understand? Okay.
This is more tight, more narrow.
Shall go ahead. Next.
Yeah, please next. Yeah.
CT cervical.
Okay.
OPLL.
Okay. Read it. Yeah.
In the CT cervical spine lateral view, we can see abnormal thing is decrease the disc space at level of C6 level and C6 C7 level, and along with that there is a loss of lordosis and straightening of the cervical spine is there. Along with that there is a OPLL behind the C4 C5 and level is there with anterior and posterior osteophytes, with narrowing of the canal diameter at the level of C5 C6 level compared to other.
Axial cut also.
In axial, we can see the OPLL. Now at what level is not mentioned, but OPLL is there.
Okay. So what type of OPLL it is from there? Maybe it's how do you classify OPLL?
Continuous.
Continuous or segmental?
Segmental. Sir, it is going for two vertebral bodies posteriorly. So,
okay.
So that's why it would be segment.
What is this then?
Continuous it would be.
Here we are not seeing it continuous, no?
Segmental, so it is sparing the
distance. Some sparing is there. Yeah.
Okay. Any other picture? Okay, MRI. Okay. You can read that.
In MRI cervical spine in the lateral view and axial view, we can see this. There is a disc osteophyte complex with OPLL also is there at the level of C4-5, C3-4 and 4-5 with significant compression of the anterior part of the spinal cord with intramedullary changes in the cervical cord, and there is a decrease the space between the behind the spinal cord. So significant compression with myelomalacia visible.
Okay.
Here also OPLL, and there is a double line is there. This characteristic of OPLL.
Okay. Okay, fine. So can these things enhance? This you are seeing some changes inside the cord. If there is significant,
yes, sir. Yes, sir.
It can enhance also. Understand? And it may mimic, like it is called pancake appearance. So it can enhance also. You can mimic like a tumor. The changes inside the cord from an extradural compression. It can produce a pancake type of picture there with enhancement. Okay, next one. Next.
Over, sir.
Oh, okay. Now, how many more minutes we have?
4.
4 minutes.
Yes, sir.
So somebody can tell how will you manage this patient?
Sir, because his cervical lordosis is his maximum compression, we can see it as at the level of 3-4 and 4-5, and there is mild kyphosis like anteriorly. So
kyphosis is there.
We will go for a posterior cervical decompression, sir.
Very
multiple level.
Very mild, sir.
So who told it is you want to go for posterior?
No, sir, anteriorly we should go for anterior corpectomy of the.
Myself, I opted for posterior cervical because the compression is more than 2 levels in the anterior.
No, the compression is at 2 levels only. So
it's what are the plus points for anterior and plus points for posterior? When will you do anterior? When will you do posterior? And anterior, what procedure will you do? And posterior, what procedure will you do?
So anterior. Yeah, go ahead.
Yeah, it's okay. Anteriorly, we should, and more than 3-level involvement, we should go for posterior. And if there is a congenital spinal cord stenosis, we should go posteriorly. And if it is an old elderly gentleman, we should go posteriorly.
Very good one. Okay. So what is the posterior procedure you will do?
Laminectomy or with lateral mass fixation.
With lateral mass fixation.
With lateral mass fixation.
So you will do laminectomy and lateral mass fixation.
You can go for open door laminoplasty, sir.
Okay, that you told open door laminoplasty. Understand? What are the types of laminoplasty you know?
Single door and open door.
French door and
French door.
One person should talk. Everybody should not talk. Okay. Okay. So you can have, what are the advantages of anterior procedure?
So addressing the pathology, sir, at the correct level, at the correct anterior, addressing the pathology at the anterior level.
So somebody told more than 3 you cannot address from anterior. So if it is less than 3 and less, what anterior procedure can be done?
Either anterior corpectomy and anterior corpectomy, plating and fusion can be done. That is best, and that's also anterior corpectomy, plating and fusion.
Okay.
Or a 360-degree we can go.
Fusion also, it is also a good option, sir.
Don't tell all fancy 360 and all, man. Understand? Okay. So anterior, posterior, you should know of all the procedures, plus and minus points of everything, what problems can occur. Understand? Okay.
Yes.
Okay. So anybody wants to know more? Actually, you know, that the presenter person didn't come. Clinical findings were not complete, so we couldn't correctly analyze. Otherwise, you know, neurology you can correctly pinpoint and tell the diagnosis. Understand? Here we do not. At least, you know, you can write to me if you have any questions or anything. I will try to answer. And I congratulate our team, Suchanda, Manas, and Paridosh, and Sridhar for giving that beautiful lecture. And if you have any doubt, please let me know. And any one of you want to present the next time. Manas, when is our next thing?
So next time it will be on a first Sunday, sir. Usually we do on first Saturday. Next time the March 6th.
Marinos also is there. Since exam is coming, I think in a month's time and all, we can have even 2 sessions a month also. No?
Okay, sir.
You have to take the call, no problem.
We'll see how many people contact us, sir. We'll do it. No problem.
Okay, okay. And then Chirag is asking if any one of the people who is attending this program, if they want to present, they can present. We will present everything. We will have one tumor case, one cauda equina problem. We will have one cellular, paracellular, one angle case. Everything we will present so that we will become master of all this. Okay.
Yes, this was good, sir. A lot of learning experience, and like one scenario of presenting complaint like foot drop. Next time also we will include more clinical patterns.
Okay, well, okay, fine. Like that, we can have some clinical scenario.
Yes.
Something like that, depending upon the case.
Yes.
Okay. Okay. Okay then. What is the cricket score? Anybody, any idea? What is happening?
So 7 wickets was down, 96 for 7, but I don't know after that.
Oh, that means we have a chance to win, no?
Yes, sir.
No, there are 7 wickets.
169 for 7.
170. There I'm not very sure.
We'll see, sir.
Okay. All the best for India. In England, 173 for 7. One fellow is batting 85. Okay.
Yeah.
Okay.
Suchanda, can you please wind up and?
Yeah, I think we should. Unfortunately, Ashutosh was not here, whatever were his compulsions. But nevertheless, the discussions went on quite well, and we learned a lot once again. And the lecture by Dr. Sridhar was really very helpful, and I think it has helped. And I could see the discussion on the chat box, which says that people were joining, and the Kahoot also gave us an idea on where we stand. And for me, it was a very poor experience.
And actually, many people have written the answer correctly. Somebody told cricket score also correctly. 173.7.
So, sir, I just wanted to ask the participants: are they getting all these mails, messages of the activities of NSI correctly? I mean, they can just write on the chat box. Okay.
We're getting.
So that's it, and
we have a few groups are there. Like I have made one group for neurosurgical resident of India. I have started when I was third year, and then once the new student are joining, they are keep editing the student. So I want to tell everybody that if somebody senior are there, to add their junior, so the more and more people get information from the like simple sharing, and no doubt we are sharing from the NSI mail also to all whosoever will come across. So that group also I am sharing, and they can also share to their department group and further. So that's where we are communicating most of the time.
Yeah, I saw in chat box many people are writing they're not getting the NSI session. Okay. NSI mail, because NSI mail goes to people who are NSI members.
Yes.
So that is why they're probably missing. So means I'll advise you people to become associate members, but then means it's not mandatory to be a member. If you want, you can get the information from friends. If you
try to become member, no?
Yeah, if you want an email you want to receive an email from NSI, it's better to become a NSI associate member. Then you'll get regular.
Everybody is not very expensive. Everybody should become. No?
Everyone, when they join neurosurgery, should be a member of NSI.
Yeah.
Okay. I think everybody should.
If you want to, if anybody.
Actually, we are giving free teaching. No, we are giving free teaching for residents. So we are not taking any money or anything. But only my request is everybody should become associate member. Right?
Yes, and second thing, if anybody wants to be part of that student group where I am sharing this detail regularly, they can just message me. I will add in that group, so you will get regular updates.
And Paridosh, just let them know we can give that how to become a membership and all.
Yes,
we should send them so that they should become member through, I think, treasurer. Treasurer is Kali.
Treasurer and secretary.
When you have the means in mid-June or something, a physical meeting, no, of this mock exam.
Yeah, mock exam.
Only NSI associate members are given the chance, I think.
Yeah. And a mock exam physical we should have. We should conduct once the corona gets over, we should have a physical exam with residents. So you can take it forward, Paritosh. Students will take call somewhere and give 1-2 day course. We can give physical examination, more like that. Okay.
So I think with all this we can end it now today. And thank you everyone, and thank you the ICON team, Mr. Sriram and Bina, for helping with us and staying with us always. So we'll come over on the next month again on the 6th after deciding on the topic, and then again a similar case presentation. And I request all the students to come forward to participate. It helps tremendously. I mean, we don't need to search for you all. You all need to come and volunteer yourself. So please contact Chirag for that. And with that, thank you, sir. Thank you for taking an extensive class.
Thank you.
Thank you for
thanks, Manas. Thanks.
Thank you.
Thank you. Thank you very much. Bye.
Thank you and good night.
Good night.
Bye.
Bye.